Chemo is still around, at least for now. So chemo can be administered orally, intravenously, intraosseously, intravesicularly, ventricularly. So there are different ways now to administer chemo. To lessen the systemic effects, that's why they put it into the ventricles now, and also to improve its effectiveness. So let's say, what do you remember from the blood-brain barrier? From that concept, what does that mean? Blood-brain barrier. Okay, so certain toxins, medications cannot cross the blood-brain barrier, correct? Which is a protection to the brain. At the same time, that can also be a hindrance to chemotherapy, meaning chemo drugs cannot cross the blood-brain barrier either. So that's why one method to administer chemo is to put in a intraventricular catheter and then administer the medication straight into the ventricles of the brain. Then we can also put chemo inside the bladder, inside the prostate, so we can administer them locally now. We have oral and IV, obviously systemic. We can also put chemo into the bone intraosseously. But care will be similar to what we finished up last week with radiation therapy. This is not testable. This will discuss how each chemo drug works, but the NCLEX will not be asking you about questions specific to a particular drug. Meaning, let's say they will say, patients receiving vincristine. The question isn't going to be about vincristine. It'll be about chemotherapy. However, if you don't know what vincristine is, can you answer the question? So that's the problem, because they won't teach you in the question. So they won't say, patients receiving vinblastine, a chemo drug used to treat leukemia. It's not going to go like that. They will just say, patients receiving vinblastine. And then you're expected to know what is that drug. And then they'll proceed with a question. Okay? The idea of giving chemotherapy is these drugs target, there are different types of chemo. There are anti-metabolites, there are anti-mitotics, there are anti-proliferatives, there are antibiotics which are used for chemotherapy. Regardless of the type, they target one particular step in the cell division cycle. So they either target it during the mitosis, or during they target the DNA, for instance. However, since they cannot distinguish between malignant, benign, or normal cells, they will affect all cells. So therefore, they will have some systemic effect as far as cell division goes. So that would be responsible for the side effects or complications that result from chemo treatment. So we'll skip the classification, because again, I'm not testing, neither is the NCLEX. They won't test you on the right, because we need certification. First of all, you need bachelor's, and then you need chemo certification. So chemo certification is about a 6-month course, and then you become chemo certified. Unless you work at a chemo unit, you can stay employed wherever you are. And when there is a need to be administering chemo to an inpatient outside of a chemo treatment center, you will just be given additional pay. So let's say $5 more an hour as your pay for your role as a chemo nurse that day. Okay, but doesn't mean you're actually performing the role for the entire 12 hours. All you're doing really is hanging the chemo drug, connecting it to the patient, and then giving instructions to the primary nurse. Okay, as simple as that. And earns you $5 at least per hour, okay, for doing something for a few minutes. One of the instructions the chemo nurse will give the primary nurse is complications during therapy. Most serious complication is the infiltration. However, since this is a chemo agent, very vesicant, meaning it's an irritant drug, highly irritating to tissues. If it infiltrates, we don't call it infiltration, we call it extravasation. Unlike infiltration, wherein what will happen if an IV fluid infiltrates? Okay, there will be edema, swelling of the tissues, right, around the vein. Here is what extravasation will look like. So it will cause tissue necrosis. Depending on how long it stayed in the tissues, we do have first aid. The key, however, is to identify it early. Chemo should really not be given through a peripheral IV because of the danger of extravasation or infiltration. It should really be given through a central line, a port, a tunneled catheter, a non-tunneled, a PICC line. Any central line is the ideal route for IV chemotherapy. However, there are certain conditions wherein the patient needs to begin chemo and the doctor orders to start it even before a central line is established. So that's the reason why we do have a few cases of peripheral administration of chemo drugs. The ideal, again, should be a central line. Now, extravasation is not exclusive to chemo drugs. We do have, remember, norepinephrine in shock. Okay, so Levophed should also be given through a central line. However, again, in practice, the patient's not in the ICU yet, or let's say there's no room in the ICU, and then the patient, it happens during the wee hours of the day, so there's no IV team, there's no one to put in a central line, so we do also give Levophed, norepinephrine IV through a peripheral line, which can also cause the same extravasation as chemo agents. So what do you think is the number one role of the RN here? Because remember, the chemo nurse will just administer this and then leave whichever floor that chemo nurse is. Okay, so you're the one monitoring for these. So once you identify it, then the first action, of course, is to stop the infusion and then call the chemo nurse. Chemo nurse is trained on how to perform because they're knowledgeable of the antidote for each specific drug. It's not the same. Some will say warm compress, other drugs will say cold compress, but there is a drug we administer called terbutaline. It will be available to you whenever a patient is receiving any vesicant medication. So it doesn't have to be, what is this? Chemo drug can also be given with Levophed as well. Okay, so the drug will be available to you as needed. So what are the signs and symptoms? So before these happen, of course, the end result are these. So there will be necrosis of tendons, muscles, nerves, or blood vessels if extravasation occurs. And this becomes a chronic wound. This is not easy to treat because now we have to, what will we do with necrotic tissue? We have to debride it, right? So debridement will cause the wound to become deeper. And then now, since it's a deep wound, is it still first, second, or tertiary intention wounds now?
Tertiary.
Well, if there's infection, it will be tertiary. However, yeah, it will be secondary. So now this will take months or even years to heal. So that's an additional problem you put on top of the cancer. However, since these patients are immunocompromised, what's likely going to happen to that wound? It'll get infected. So they'll go septic, possibly die. So therefore, what's the best approach here? Okay, or if we can't prevent it, early, yeah, central line would be the best prevention. Or if we can't, then at least identify it early. So there'll be localized painful reaction, burning will be the most common complaint. So these are the highly vesicant medications, chemo drugs given IV. Just be familiar. Again, I won't test you about the drug, but you need to at least know what that drug is. Now, so far, this is your first semester. Have you ever seen these names before? No. So therefore, if it doesn't look like cardiac drugs, respiratory drugs, doesn't look like anything like that, that means this must be chemo drugs. Okay. But you know how it goes when you're under pressure. So don't go guessing on the NCLEX. Each question matters. Okay, so make sure if you have to guess, that should be the best educated guess you have to make on the NCLEX. Antidote again will be available, but the antidotes are only administered by the chemo nurse. So again, your responsibility is basically what? Yeah, once you identify or suspect, stop and then call. Okay, then they'll take over from there.
So what is the
Terbutaline, that's the drug that's going to be administered by the chemo nurse. Yeah. But if it's anything else, so let's say it's Levophed that infiltrated, you can administer the terbutaline yourself. However, this is chemo, so they have to take care of it. Plus, it may not be terbutaline. It may be another drug that is used as an antidote. It's really chemo specific. You understand what central lines are, right?
Yeah.
Okay. How many do we have?
One.
How many types of central lines?
Oh.
Okay, we have 5 technically, right? So we have, yeah, so central catheters can be tunneled or non-tunneled. So that's 2. We have PICC lines, then we have ports. Okay, so all of them are central lines.
Okay.
The 5th one is the hemodialysis catheter. But do we use hemodialysis catheters for any other purpose? Only for chemo. But
I mean for
correct. A dialysis catheter is only yeah, but technically it's a central line because it's in a large vein. It's in a large vessel, femoral, subclavian, or jugular. I'll skip over hypersensitivity because here the management really is the same as with anaphylactic shock. Okay, doesn't make a difference. So management, identification and management is exactly the same. So this is what I mean by, you can just be familiar with the name. So table 12-7, I won't test this. So here you can see the action of each drug. They all interrupt the cell division cycle. So either at the division wherein it prevents the RNA, DNA from being split. Okay, so it depends which drug you're giving, and then they will interrupt the cell division at some point during mitosis. Like here, 5-FU, hydroxyurea, you've seen this, right? In sickle cell disease, remember? Yeah, that was treatment for sickle cell disease. It's also used for cancer. Then you have these antibiotics. So these are one of the oldest medications. They're still used today. Hormonal agents, these are for prostate, breast cancer, because those cancers do feed on hormones. So therefore, if you, the idea is they'll I'll give you an example. Cancer cells are gluttonous. Okay, they eat a lot. What do all cells eat? Sugar. Okay, so they love sugar. Now, there are treatments not approved by FDA, so those physicians don't practice in the US. So they either practice around the border, so Canadian border or the Mexican border. Okay. So I remember when my brother was alive, he escorted a prominent, politician back home because he was given a few months to live, and then he heard of this unconventional therapy in Tijuana. So he went here. All my brother did really was just sit in the airplane. Okay? He was paid handsomely, but because he's a doctor, but he didn't really do anything. He just escorted. The rich man just gave him lots of money. Come with me. I need you to go with me to Tijuana. So anyway, so they stayed in Texas and then drove to Tijuana, and then he was admitted there for about a week. So it was a ICU setting. So the doctor there, the treatment, why it wasn't approved was he drops the patient's sugar down to like 20s. Okay, he gives him lots of insulin, calculated, of course. So that's why it's an ICU setting. And then after that, they will give the patient chemo-tagged glucose, meaning this glucose was immersed in chemo, so meaning each glucose molecule carries chemo drug. So now, since who's eating most of the sugar? Which cell? The cancer cell, especially. Of course, it will also damage the other cells, but more especially the cancer cells. So therefore, when the cancer cells were starved and then you give them lots of sugar, they will eat, they'll gobble it up, and then instantly kills the. But again, it's dangerous though. It could kill the patient. He survived. He's still alive today. That was 20 years ago. It's not approved. Too dangerous. Yeah. So that doctor is American. He didn't get. He can. I mean, he's not under U.S. jurisdiction. He's in Tijuana, so he's not, doing anything illegal. Yeah. So anyway, so that's the idea of different ways to kill cancer. Again, most of these treatments successful, but carries a lot of risk, and if the risks really outweigh benefits, so FDA won't approve these things. But that guy had nothing to lose anyway. He was gonna die if he didn't get treatment, so he tried it.
Did we review that you just spoke about?
No, this part here are just reviewing the central lines, which we did when we did central line dressing change.
You gonna ask questions?
I mean, you should know central lines already. So what's your number one duty with central lines?
Prevent
infection.
Because what's the number one complication of someone who has one?
infection.
Okay, sepsis. So therefore, signs and symptoms of, yeah. So it's always starts local and then of course go to systemic. And then you already know sepsis and septic shock. Let's review dressing change because that's how you prevent infection in central lines. So what type of dressing do we use?
No.
No, I mean, do we use gauze or clear dressing? Okay, you can use either, but how often do we change? If we use gauze,
92 hours.
48 hours. So if there's gauze, so if this is the skin, right? So if you put gauze here and then the tegaderm, how often do you change it now? 48 hours, because there's gauze. So the gauze absorbs sweat, any moisture, so it becomes a medium for bacterial growth. However, if there's only tegaderm, no gauze, 5 to 7 days. Which way do we remove the dressing? Because you have to remove the dressing before you put on a new one. Yeah, which way?
You pull with you.
So this is the, let's say it's a catheter here or a catheter here. Which direction do I pull the dressing off?
Down.
Oh, the direction that.
Toward the insertion site, okay? So which way is central line always going toward? Toward the heart, because all veins return to the heart. So if it's the jugular vein, so which way will you pull? This way or that way?
Down.
No.
Down.
Toward the insertion site, which is toward the heart. So if it's like this, which way do you pull?
Down.
This way. If it's like this, which way do you pull? Clear? Why are we doing that?
To prevent the cabbage from coming out.
Yeah.
The catheter will be dislodged because remember the tegaderm is stuck to the catheter. So therefore, if it's inserted this way, you don't pull downward because it's gonna pull the catheter out with it. All right, children, and flushing, because that's another duty. We
Yeah.
flush it, we're using it, so we how much do we flush the central line with? 10 ml.
Yes.
What
Flush.
can we use a small syringe and then flush with 3 syringes?
Yes.
No, only a 10 ml syringe or 12 ml must be used. Okay, you cannot use a 3 ml and then flush 3 different ways. Okay, no, right? No, it's actually the pressure.
Pressure.
Yeah, the pressure is higher with a smaller syringe. It should be a 10 or 12 ml size syringe only. Are we clear? And how fast do we flush? No.
No.
Peripheral, we flush slow, but the central line, we flush 5 mLs per second. Fast, 5. Okay, 5 mLs per second.
And not 30.
Not 30 is too big. So 10 or 12 ml syringe size should be the one you use to flush. Okay, only flushing. You can use any size to administer medication, but when you're flushing, should only be 10 or 12 ml.
Why do you push fast versus slow?
To clear the line, because remember, central lines are long. So if you flush slow, is it gonna clear anything? It won't clear anything. So if for you to clear, right, it should be positive pressure. Positive pressure flushing. Okay, so side effects for chemo, nothing different from radiation. So did we have stomatitis in radiation? So we'll have stomatitis here again. Do we have nausea, vomiting?
Yeah.
Do we have alopecia? Do we have bone marrow suppression?
Yes.
Same thing.
Do we have to learn medication?
Yes, we'll get to the medication shortly. Let's start here. Now, management of CINV, which is chemo-induced nausea vomiting, because there are 3 types of nausea here. It's not just acute nausea. These patients will have delayed nausea, meaning they had chemo today, but they'll stay nauseous up until next Friday. Okay? So that's delayed nausea. There's also anticipatory nausea. Just the thought that, oh, I'm gonna have chemo tomorrow. They'll start having nausea now. So therefore, do you use the same drug for all of them? No, each drug, each antiemetic has a different action. So some of them are good for preventing nausea. Some are good for acute nausea. Some are in combination with other drugs used for delayed nausea vomiting. Okay, so the single most life-threatening complication of chemotherapy, and this will be the same for radiation as well, is myelosuppression, which is bone marrow suppression. Why? Okay, so it will suppress all 3 blood counts, right? Because all our blood cells are produced in the bone marrow. So the patient will have pancytopenia, which are anemia, neutropenia, and thrombocytopenia. So do we institute infection prevention?
Yes.
Do we institute bleeding precautions? Do we institute, how do we manage anemia again? It was on the quiz today. Balance activity with rest. Okay, energy conservation. Because what's the number one symptom of anemia? Fatigue. And shortness of breath, right? Dyspnea on exertion. Right, so the drugs I mentioned earlier on the blueprint, right here, these three, these are brand names. Now the generic are here. So Epogen is called erythropoietin. So because is it better to stimulate bone marrow production or to give blood transfusions? Hey, blood transfusion carry a lot of complications, right? Not to mention possible reactions. So this one will be given. So what's your indication? How do you know it's safe to give this? Blood count. Okay, so therefore, what's the normal hemoglobin? 12 to 15. Okay, so therefore, if it's already 12 and 15, do we still give it? Don't worry about the male female. There is no gender on the NCLEX. Yeah, that's a good thing. The patient will always be client. Yeah. Of course, you won't have a male pregnant woman, right?
You know what?
So that's one. Another, the counterpart of erythropoietin for white blood cells is called filgrastim. Filgrastim is called Neupogen. Neupogen. This is brand name. Generic is filgrastim. This is the counterpart of erythropoietin, which is for RBC. This one is for WBC. There's also a sister, which is called Neulasta. Neulasta is called pegfilgrastim. That's Neulasta. Pegfilgrastim, filgrastim, same sounding anyway. And then lastly, the one for platelets is called oprelvicin. This is for stimulating the bone marrow to produce platelets. Okay. All are given via sub-Q, although erythropoietin does come in, the name is Erythacrit, which is given IV. That one's IV, but oprelvicin, pegfilgrastim, once a week. And erythropoietin is given via once weekly subcutaneous injections. They're in a pre-filled syringe. Except erythropoietin. Erythropoietin sometimes comes in a vial, depending on the brand. So here's oprelvicin and erythropoietin. The side effects though, which are not mentioned here, where will you get them? From the drug book. Because they're dangerous. Let's say you gave erythropoietin even and then didn't check the hemoglobin, which is already normal. You still gave it. What could happen? No, this will increase RBC.
Yeah.
Clotting, okay, could cause hypertension, clotting. Clotting can be deadly. Right. And then for oprelvicin, this drug, I know the drug book will say this will cause pulmonary edema because this will cause water retention.
Which one?
Oprelvicin. And then for the filgrastim, they've been known to cause bone pain, like really painful bone pain, among others. So patients may get all three, okay, depending on the let's talk about when this will be given. Okay. Have you heard of the term nadir? Okay, nadir is not really exclusive to the healthcare field. They use this noun also to this, in politics or in engineering. What it means is the lowest number of something. So here, for instance, let's say in this statement, so you're in your lowest point. Let's say you're a businessman, you went bankrupt. So we call it nadir is a period. Okay, it's a time period. It's a concept. It's not something you can touch. Okay, so I'm in nadir right now financially. I'm in financial nadir. Or in the case of Trump, he'll probably say I'm in my political nadir. Okay, so here in nadir, in chemotherapy, this is the time. Remember, it's a time period. This is a time period wherein the blood counts are at their lowest. Each chemo drug will have a different nadir period. We can't generally say, oh, all chemo drugs have this nadir. No, it will be specific to the drug. So that's why, have you seen IV chemo? IV, okay, not oral. Have you seen an IV chemo given every day?
No.
No, because of the nadir. Because the chemo drug causes bone marrow suppression, correct? So when they reach nadir, the patient must be allowed to recover. And to facilitate that recovery, that's why we give these drugs. We give erythropoietin, oprilvikin, filgrastim, okay, to facilitate the replacement, correct? Because otherwise, can they die in between treatments?
Yes.
Yes. If their white blood cell count drops so low, and then you continue giving the chemo drug, it can literally kill the patient because they're worse than AIDS patients.
Yeah.
Okay, that's how much their immune system is so suppressed. Okay, they literally have no protection. You sneeze at them, they'll get sick already. Or you just look at them. Yes, they could already get sick. Okay, so they could go into sepsis and then they can't recover.
All three can be given to them, but you have to do the test and check.
Yes.
Okay.
All three can be given because they have different actions anyway. But
Yes.
you have to just manage the side effects. Any question about nadir? So the drug's nadir determines the frequency of drug administration. So some chemo drugs will be given once a week, once every 2 weeks, once a month. Okay, it really depends on the nadir period. So meanwhile, during the nadir, make sure the patient is really protected from infection, and then you of course administer any of those 3 drugs. Kidneys will be harmed as well for chemotherapy. So make sure you monitor what? Urine creatinine and okay, it'll be urine output at home because of course we're not drawing blood at home. So the best thing you can do is monitor urine output. I'll talk about capillary syndrome another time when we get to acute respiratory distress syndrome. So these are the effects. So system by system. So we talked about the bone marrow. Hematopoietic system is the bone marrow. Next is the kidneys. Watch for renal toxicity. Next, watch the heart and lungs. This can cause the connective tissues to be inflamed, causing pneumonitis or pericarditis. Reproductive system, patients may be advised to, if it's female, then bank your eggs. If it's male, then bank your sperm, because they can get sterilized. Okay, they may become sterile after the treatment. Neurologic system, the toxicity can cause a phenomenon known as chemo brain. Chemo brain is literally a deterioration of cognitive function, meaning your IQ drops. However, good thing is you can recover this after treatment. You survive the cancer, you will regain it. When my friend in California, who is only 2 years older than me, when he had his chemo for, he had nasopharyngeal cancer, stage 4. So he had chemo, radiation, extensive treatment. Don't worry about him being sterile. He's not planning on, he's still single until now. Actually might benefit him. You don't want him to reproduce. Okay? That's another different story. Okay. So anyway, so when he had chemo brain, he could not remember names. It's okay to forget names of our high school classmates, right? Or a few college friends. It's okay. But people he works with every day, he could not remember their names. So he was a nurse, he was actually an oncology nurse. Yeah, that's what his field. Well, it's not like you're immune from cancer if you work in cancer, industry. No, because he works remotely. Like he wears a shirt and tie, but then pajama bottoms, that type. He works at home. So he worked for Quality Oncology. What he does is just monitor. He's a case manager for patients. So what they do is coordinate care and then follow up with the patient's symptoms. How are they handling the treatment, and then coordinate therapy if needed. They call resources and all that. All at home. 6-figure salary.
Yeah, really nice.
But it's a very, people at his work retire and die doing it. They don't resign because, why would you leave?
Wait, Professor, now that you're talking about that, are you at risk of getting cancer if you work on the oncology field?
No.
Like
Why?
the medicine?
Well, we have protections. We have chemo gloves, we have radiation. Unless you work in radiation and you're careless, so yeah, you could get leukemia from radiation.
Or do you get more radiation?
Yeah.
I don't know, maybe. Okay, so we talked about the cognitive impairment. So that's the chemo brain phenomenon.
Oh, when they can't remember.
Yeah. So he had to quit working because it was affecting his job also. So he had to quit 2 years. Yeah. So he quit 2 years because exactly that reason, he didn't want to compromise his patient safety. But as soon as he was back 2 years later, he just made a phone call to his boss and said, "Hey, how are you? Hey." And when he said, "Do you have an opening?" The boss just said, "When can you start?" Okay. So meaning if you do your job, yeah, well, you get it, yeah. It was never replaced, apparently. Her boss also runs because he went to visit, and then we drove around New York up and down. Some place called Waverly, New York, some godforsaken county along I-80, I think. Her boss was running it wasn't her, it was her husband's. They have a homemade ice cream shop. So like in the middle of a rural county road. And there was this nothing there, but that cute little ice cream shop.
No.
Yeah, and she's there, and then in the back was her computer.
Oh.
She was working, and then at the
With the ice cream shop.
Yeah.
Wow, smart.
And the ice cream was delicious. Can't find those flavors anywhere. They made them themselves. Fatigue we discussed already, so this will be same treatment for same management for anemia. And if you need blood transfusion, then blood transfusion will be given. Here are complications long-term for chemo drugs.
What's considered long time, like
Forever.
for chemo?
Forever, pretty much. Well, not technically, maybe 30, 40 years, which is forever for some people.
Peace for so long. Doesn't work with surgery.
Okay, so let's take a look at it one by one. So this loss of taste, smell, and touch is from neuropathy, so nerve damage. The abnormal balance, tremors, or weakness could be also nerve damage. Avascular necrosis, so this would be for, let's say you have extensive chemo and then it damaged your blood vessels. And if you develop any of these, then that will have long-term complications, including heart failure. And this would be the worst, right? And then dental caries. This would be from combination. Let's say you also had radiation to the head and neck, so that will affect the bones of the jaw. Dry mouth is called xerostomia. And dysphagia, this would be irritation. So my friend had this, so he had to have a peg tube for about 6 months. Yeah, he's eating now, but he has xerostomia. So he can't eat without water. So the first thing he'll order when we go out, when we went to Vegas 2 years ago, so he would order water first before he'd look at the menu. Water, please. You keep drinking water because otherwise he can't swallow. Because couldn't he choke?
Yes.
Yeah, you could choke if you're, let's say you put bread in your mouth. What moisture is in your mouth, what little moisture goes into that bread, and then nothing left. No, you can't swallow, so he uses water, a lot of water. And all of these, so the bone consequence will be osteoporosis, and then you can develop other forms of cancer from chemotherapy, just like radiation. So these are consequences. But you've never seen it on TV, right? When you say, did you receive this drug and then you develop this? You won't see that because you already are notified. Then you sign consent, understanding that this could happen to you. So due to bone marrow suppression, so monitor for and prevent infection and bleeding. Chemo again, we'll skip. We're not the ones giving chemo. Okay. But we are monitoring the patient. So therefore, we talked about extravasation earlier, right? So do we want to treat it or prevent it?
Prevent it.
Okay, so here's the early indications. There's actually a fourth. No, only those three. So these are signs of infiltration or extravasation. Of course, we're only worried about extravasation because it's a peripheral line. You won't worry about this if it's a central line. This will not happen. So peripherally administered chemo, so make sure you monitor this. In my experience, I've only seen it once. I've only had to take care of a patient receiving peripheral chemo through an IV line. It was probably 2004 or 5. Yeah. And it was the busiest shift of my life because I literally had to watch this patient every 10 minutes. I couldn't wait until the infusion finished. But the infusion runs over 16 hours. So it was probably 7 hours left during my shift. So I still had about 7 hours to watch. It's a hassle. And what's your action again? If you see any of these 3 signs, all right here. So stop it and call the chemo nurse. Rapid response don't need to be called. I mean, this is local. So it's the chemo nurse you need first to administer the antidote. So there's a kit. Again, the kit with the antidote is specific to the drug. That will be provided by the pharmacist to the chemo nurse. Right, so nausea vomiting. How you prevent it is, let's look at the medications. It's too far. So let's just go by and then talk about it when we get to the drugs. There are up to 5 medications that you could be giving for nausea vomiting. Let's go back up because they were actually mentioned up here. Okay. So these are the combination antiemetics that can be used. We can use steroids. Steroids are never used alone though. It's usually given with Emend, which is I don't know what the generic for Emend is, but steroids are given with Emend so that you can handle delayed nausea vomiting. Yes, sir.
But just to be clear, you're giving medication to offset the effects of the chemo.
The side effects.
Besides-
Yeah, so let's say chemo induced nausea vomiting. So these are the drugs that we'll be using. So we've got phenothiazines, and you know about serotonin antagonists, right? Like ondansetron. Yeah, Zofran, ondansetron, dolosetron. So those are good for preventing nausea vomiting. So you don't use that for acute nausea because that won't do anything. So if you want, yes, if you want to treat acute nausea, it'll be phenothiazines. Or the serotonin antagonist again is used for prevention. And then histamines will also help. Sedatives can be given if we have nothing else, meaning nothing else will treat the patient's nausea vomiting. I mean, they continue to not eat and they're miserable. Yeah, so we give them sedatives, which is diazepam. So we give them Valium, knock them out. Have you ever been nauseous if you're sleeping?
No.
Impossible. You have to be awake to experience nausea, right? So we sedate them. Sedated, then no nausea. But that's of course last resort, because how will this patient eat now if they're sedated? Yeah, so you have to consider that. Oh, spilling. Sorry, I forgot to mention spilling. If, let's say, the chemo drug spilled for whatever reason, the bag got punctured or the tubing leaked, do not handle it with regular gloves. There are special chemo gloves because they can burn through your regular latex gloves. Okay, so make sure if you don't know what you're doing, then just call the chemo nurse. They'll clean it up. But if you do, then grab this chemo spill kit. It's basically a bucket, and then everything you need in there is in that bucket. Doesn't happen too often, but if it does, okay, there's always a spill kit on the floor if chemo is ever administered on that floor. Okay, let's talk about stem cell transplant. This is now outside chemo. The idea here is to replace the patient's bone marrow. So what type of cancers is this? Bone marrow cancers, okay, stem cell cancers like leukemia, for instance, they're in the bone marrow. So leukemia can be treated with stem cell transplant. Remember the idea of plasma exchange, plasmapheresis?
Yeah.
What did we do with plasmapheresis? We removed the patient's plasma and then we gave them someone else's. So same idea here. So we will destroy the patient's bone marrow first and then give them someone else's stem cells. Because we can't transplant the stem cell directly, because if you put someone's stem cell in there with the cancerous stem cell still in there, will it work?
No.
No, because the new stem cells will just be boxed out by the cancerous stem cell. So you have to eradicate the patient's own stem cells first and then give them someone else's stem cell. You mentioned dangerous. Yes, because before we can do it, so how do we eradicate the bone marrow? We give them extensive high dose radiation and chemo. wipe out the patient's entire bone marrow. So now what will happen to their blood counts? Tanking to the lowest level. Could they die at this point? Yes. So during that step, so there are many steps in the stem cell transplant. It should be illustrated here. It's not. So I'll just describe it. So we have the extensive phase first. Extensive phase means the patient will receive high dose radiation chemo, wiping out the bone marrow. And then the patient, of course, will be in a ICU setting, private room, protected, strict reverse isolation. And then they will be given the transplant. Now, two things can happen in the transplant. When you when you put in the stem cells, if it's successful, it will be called engraftment, meaning the graft took hold, the body, it's successful, meaning it took over the bone marrow, and then the patient will now start producing non-cancerous blood cells. Or this could happen. What was the idea of transplant rejection? Who actually killed who? In organ rejection, the one we did 2 weeks ago. It was the patient, right? The patient's body rejected the graft, correct?
Yeah.
So we had hyperacute, acute, and chronic rejection. This will be the opposite. So here it will be the graft that's going to kill the patient. Why? Because what did we do before we put in the stem cells? We wiped the entire bone marrow. So is the patient able to defend themselves? No. So in the event that, let's say, the doctor who performed the stem cell transplant, or any of the lab scientists who handled it, missed a few active lymphocytes that was in the stem cell. If that happens, then the graft is more powerful than the host. So therefore, the patient will be attacked by the graft. These are the manifestations. So let's look at what's the largest organ of the body? So therefore, what will be the first system that will have manifestations? Okay, so the patient will have this, show you a picture, what the skin will look like. Okay, skin will look like this. That's GVHD. Let's look at the whole body. So that's just on the trunk. So that's how it will look like. Okay, so that's the patient's, reverse. It's actually the graft now attacking the host body. And that's just the skin. Now inside, the liver, the spleen, all the internal organs will also be attacked, but those are the most commonly attacked organs. The liver, the spleen, the kidneys will be attacked, and this is what the patient's skin will look like. Okay, this is from GVHD. What's the treatment? Well, treat the patient symptomatically first. Okay, make sure they survive. If they go, liver failure, so you treat that. But the GVHD itself, well, how did we treat rejection? Same. So this patient will be receiving immunosuppressants. So of course, the patient has no immune system to speak of, so it will actually suppress the graft. So the lymphocytes in that graft will be affected. We'll skip immunotherapy. Like I said, we'll only do the surgery, chemo, and radiation, which we did. So this part is focus on the 5, right? 5. So anemia, thrombocytopenia, and neutropenia. 4th will be nausea, vomiting. 5th would be stomatitis because the alopecia is simple. Okay, fine. Let's include the alopecia as well. So they'll be here in this section, nursing care. So that's caring for a patient, preventing infection, preventing bleeding, conserving energy. Okay, it's long, so I'll leave you responsible for reading. We'll end with so here's the the anemia part. Okay, this is the anemia, and management should be somewhere there. If the patient ends up end of life, say terminal cancer, stage 4 or highly metastatic, for instance. So we're now doing end of life care. So what will be your priority?
Provide palliative care.
Which is pain management. Right. So pain management, what will be the route?
Oral.
Depends on.
Where are end of life patients located?
And hospice.
Hospice or at home? Do we have IV sites in hospice? No. So it's either oral or rectal. Okay. So oral, yeah, so all morphine will be oral.
That's the whole thing, we don't wanna stick with patients.
Yeah, no more IVs, sticks. Okay, that's the
That's not hospital.
right. So when you go to hospice, there's no IVs involved. It's all PO or for rectum. All right, so there are 6 oncologic emergencies. We'll only be discussing 4 because the 2 you already finished. So we already finished sepsis and DIC. Sepsis was earlier this semester, and DIC you talked about
Yeah.
last semester. So we only have 4 remaining. First, it's on table 12-13. When it says emergencies, what can you say about these conditions? Life-threatening. So was sepsis life-threatening?
Yes.
Was DIC life-threatening? Okay. So number 3 is superior vena cava syndrome. So this is going to happen with patients who have cancer tumors in the thorax. So what are structures that could be compressed by tumors growing in the thorax? Lungs, heart, and the vena cavas. So the superior and the inferior vena cava can be compressed here. However, the inferior vena cava compression is not really going to cause immediate death, but SVC syndrome can. Okay. Because where is the blood coming from that enters the superior vena cava? Where is that coming from?
From the body,
Which part?
the lower and upper part.
Superior.
Upper.
Only the upper. Only the arms, shoulders, neck, and the head, correct? So what will happen if this is obstructed?
So we're not.
It's the patients will be superior.
Okay, so let's look at the manifestations. So how is this tested? For any emergency, what have you noticed? What are the 2 things that are tested? It's an emergency.
Intervention.
And before you can intervene,
Assessment.
you have to recognize it first and then intervene. Okay, so testing items will be signs and symptoms. You have to be able to recognize it when it's happening, and then interventions. Okay, don't worry about the interventions because you've talked about most of them already. For in the case of SVC syndrome, the doctor will do most of the work. It's not easy to manage SVC syndrome. Therapy is radiation, so there's really no immediate intervention we can do here. Surgery is seldom done for no emergency surgery in SVC syndrome. So you just support the patient because what type of shock can result here?
Obstructive.
Obstructive shock can result. Okay, and so if it's obstructive shock, then you treat the shock, and then extensive radiation chemo shrink the tumor so that they'll stop compressing the SBC. Let's look at signs and symptoms. How do you recognize? So it'll be, first, there will be compression of the laryngeal nerve. So that will cause hoarseness. Patient will also complain of shortness of breath. There'll be edema, facial, neck, periorbital edema, and edema of the arms and shoulders. You want to see a picture? I had a ex-girlfriend actually who had this. She died in Jersey.
Right.
She died December 2004. She didn't take visitors. So we just imagined how she looked like. Well, these people look good actually. Right here. So you look like that. So the facial edema, neck edema. Okay. And then look at the arms, all edematous. And then you can imagine also the intracranial pressure at this point.
Only here?
This is actually good. They don't have bad enough pictures. So the facial edema is really bad in SBC syndrome.
But I don't see now something danger. This one there?
Yeah, so here, see the periorbital edema? So here, this is pretty bad now. Look at that. Look at this guy. Okay, already intubated. Yeah, she had non-Hodgkin's lymphoma and, non-Hodgkin's, so her tumor was in the lymph nodes close to her, yeah. So those are your signs and symptoms. And monitor hemodynamics because it will drop, it will cause shock. Next, spinal cord compression. This is number 4. So if your spinal cord is compressed, what are signs and symptoms? Will there be pain? Could there be paralysis? Paresthesias? Okay. Could you have some, depending on the level of the, did we do spinal cord injury yet? No, okay. So this, depending on the level of the injury, so there could be bowel and bladder problems here as well. So here, pain or paralysis, or at least loss of sensation, bowel and bladder, already mentioned. Okay. And the treatment, again, it's the doctor that does it. Radiation surgery can be done to decompress. Number 5 is hypercalcemia. Where did this calcium come from? So what type of cancer is most likely causing this? Either a primary or a metastatic cancer of the bone. So once you have a tumor in the bone, what will that tumor do? Break down the calcium from the bone, leading to hypercalcemia. Can you die from this? Yes. Manifestations? All right. And how do we treat hypercalcemia, if you still remember from last term? What are the first 2? Fluids, it's not complete though. Fluids with diuretics. Okay, so it's massive fluids with diuretics to flush out calcium. And what else will give? So here's fluids with diuretics. And how else do we, where do we return, how do we return that calcium to the bone? By phosphonates. Okay, by phosphonate therapy. So that's what, number 4, 3, 4, 5. Number 6, last is tumor lysis syndrome. So this is number 6. Unlike the first 5, were the first 5 good news or bad news? They were all bad news. This one is good news and bad news. You want the good news first or bad news? Good news first. The good news is the chemo and radiation is working. It's killing and destroying the tumor. You want the bad news? It may also kill the patient. Okay. How does it kill the patient? But we can treat it. That's why we're talking about it. So the danger of tumor lysis syndrome is it doesn't happen in the hospital because this doesn't happen right away. The patient, yeah. So when the patient's already home, then this occurs. So there are two things that can kill the patient here. So when you destroy tumor cells, it's just like another cell. So when you destroy cells, it releases potassium, correct? And they release uric acid. You remember gout last semester?
Yes.
So this patient will have gout. However, the gout is the least of the problem here. Patient will really die from acute kidney injury because the uric acid will destroy the kidneys, both of them. So patient goes into AKI plus the hyperkalemia, of course, will do what? Cardiac arrest. Okay, so those two things will kill the patient. So management, what are the interventions? Signs and symptoms first. So this will be signs and symptoms. You already know gout, you already know hyperkalemia. So here are your manifestations. So weakness of the muscles, right? That's hyperkalemia, same as hypokalemia. Elevated blood pressure, shortened Q waves. So these are the, what's the manifestation on the monitor for hyperkalemia? All peak T waves. Okay, very good. And GI, there you go. And then for once we get the kidney injury, so now you got the flank pain, oliguria.
What's crazy is a lot of these symptoms are mimic chemo. Like, lungs being dominated. And fatigue.
So you have to teach the patient because it may not be you, it may just be the patient and the family. So you have to teach them the manifestations because when does this happen again? At home. So the patient's already at home, they think they're recovering. Okay, they were giving the news that, oh, it was good. Okay, and then this happens. So treatment, how do we treat gout? Hyperuricemia? What were the drugs?
There was a medication.
Colchicine, allopurinol, right? And then the diet, of course. What diuretics do we avoid?
We avoid,
Okay, so we give loop only, so therefore we're avoiding. Thiazide diuretics are avoided. Okay. So you give lots of fluids for the AKI. And the fluids also will help eliminate the uric acid. For the potassium, how do you lower potassium? Okay, Kayexalate is sodium polystyrene sulfonate. And how else? Sodium bicarbonate.
Yeah.
And dextrose with regular insulin IV. And what's the other? Calcium what? Calcium gluconate. Okay. Or if needed, we give them dialysis.
Oh, God.
All right.
Hole in that in here.
That's it.
Nice.